So because of his foot, you guys can see how the front is off the ground. He has to rely on the cane. So that's needs to be addressed.
Yep.
So anyway, this is diabetic Charcot. There's multiple stages, as I explained to you guys in the past, and in regards to location and in regards to the mechanism of attack in regards to the inflammatory stage. So there's 5 locations usually in the ankle and the foot, and 3 stages in regards to inflammation. So anyway, he came to me, the whole foot basically. This is how he was walking on this shoe, and with a big discharge on the back of the bottom of this sock. So when you look at this, please, on the bottom, see how this is rocking on the bottom. Can you guys see this, how it rocks?
Yeah.
So when this is rocking, that's called a rocker foot. And that's obviously not the shoe. The shoe was nice and straight, but his foot is not. So when we look at the foot, clearly we see, you guys would look at it as if it's swollen. This is not swelling, this is all bone. The bone between the ankle and the heel popped out, completely is out. And it's actually dislocated totally. And now we can feel the bone all the way on the bottom. So he's walking on the bone in a rocker form shape. So it's a convex foot rather than a concave. So creating this diabetic ulceration that we clearly see right there, we'll culture today. So this is all bone, and unfortunately is a huge problem. So in this situation, we got to put a delta frame. I like the Arthrex brand. It's called Arthro FX. So we'll use that and try to put everything back together. It's not going to be one procedure, no question about it. And then we'll have to attack the joints and fuse the joints. So when we look at the foot, obviously this whole bone inside is popped out. It's all in here, and it's kind of reversed, so it popped out this way. So if you stay right there, the bone looks like, this is the bone, basically, in a nutshell. This is called the talus, which is locked in between the heel and the tibia. I don't know if you guys see it. So what happened is, in his situation, he took this whole thing and rotated outwards, and he's walking on the back part of it, and you'll see the x-rays as well. And this is like this, and the whole heel is cocked up because of the tight equinus. So that's going to be severed to bring the heel back up. Otherwise, it's right now he's walking like this. So that's just totally wrong. So he has a dislocation of the talus, and due to the Charcot diabetic arthropathy, and he's been walking on it for several months. So when you look at the x-rays, without names, if we may, you can see the leg bone, the heel bone. We see that little bone. That little bone can concentrate, if you guys can bear with me, which is the triangle. That little piece right there, where my fingers are, that's the triangle down there. So basically the whole thing popped out, and he's walking like this on it. So it popped out, and it's that way. And this leg is now touching the remaining parts of this talus, which more likely is lodged in with the head, and this is the heel bone. So it's like this. So what we have to do is put a frame and distract it to try to see what we can salvage or use some of this bone as graft, versus bring this tibia to the heel bone and fuse that. There's multiple ways of doing it. Ideally, if we need the length, what I like to do is a slide, an anterior slide of the tibia. So you cut the tibia and you slide it downwards, and there's framing, there's different hardware for that, which we will show you as well. So the other thing is, we can put a nail, they call it an IM rod. In this situation we cannot use, because he's got a hole underneath his bottom of his foot. So that's a no-no. So the only other option at this stage is to put a delta frame that we were talking, and an external fixation to distract this whole thing, calm this foot down, and then reconstruct this whole foot. That's the only thing we could do at this stage. His leg is not of the best. He knows that he possibly may lose his leg. So if you left it like such, it can blow up and get infected within a week or a month or two. versus take his chances and fix his foot, and that's what I would recommend. So he's walking on a hole on the bottom. We're going to culture it. The skin is not that great. To do the frame is 2 screws, basically they're pins, and what we do is at the crest, usually what I do is follow the little hump of the anterior compartment legs, and that's what I usually do. You follow the crest a little bit slightly curved to you want to go along the crest itself, and they have guide wires and what have you, so making sure, because you can easily slide off of it. So 2 pins, 1 pin in the heel, you put your rail on, and then you stabilize it, and it's fairly basic, and you can distract it and hope that we can put everything back into play. If not, then what we have to do is do incisions as well, and to remove whatever we have to. But I think at this stage we have to put a rail, try to distract it, see where we are, and then come back and do the incisions and get that done, reconstructed. So that's basically a diabetic Charcot. In this situation is a dislocation of the talus, so it's a hindfoot Charcot, and we'll get it done.
So
Thank you.
this is a Delta frame. It's an external fix. We call external fixation device, made by Arthrex. They call Arthro FX. As we can see, the 2 pins that are capped, one is in red, one is in black. Those are typically the first that are inserted into the tibia, into the shin bone, and the clamp is applied, making sure. Now there's devices for application. There's a single inserter versus a dual. I use the dual because it's kind of precise in keeping them parallel to each other. If they're not parallel, you can break them basically at the weak link between the interface of the thread meeting the shaft. So these are bars. The black things that go down are bars. The middle one is called a crossbar for further stability, and then there's a middle one going down to the foot. That middle one, and then there's a pin. As you guys can see, the pin going behind the big toe. That pin going behind the big toe is to manipulate the foot in either dorsiflexion or plantar flexion. So therefore, if you want the foot further up or further down, so gas pedal method, down versus up towards the patient's face, in regards to correction, for further additional correction. So the heel pin, as you guys can see on the side of the heel, so it's a frame and you put it together. It's very, very easy. It's great for multiple things, including, in this situation, diabetic Charcot. He sustained a rocker bottom foot. As you guys remember, the previous video was the foot looking like a rocker, and the shoe was curved up within less than a week. Developed an ulceration on the bottom. He could lose his leg. You can't live and sustain your life like that, so he required reconstruction, but it's staged. So what we had to do is, we're going to show you on the bottom, is the skin graft, and then less than 2 weeks you got to come back and put the frame on, and then further reconstruction, and that would entail basically a pan-talar fusion, which is multiple joints, fusion of the ankle and the joints below, called the subtalar mid-tarsal joints. So in this situation, the leg, as you can see, coming down to the outside, it's very, very nicely straight. Let's see the angle. That's phenomenal. So the plantar flexion of the foot, as you guys can see, that's what I wanted, because in his situation it was actually dorsiflex. So when you take the pins, the foot wants to go towards the patient's nose. So that's a problem, because it's called calcaneal, means heel equinus. So the heel was cocking up all the way. I had to do a percutaneous lengthening stab incisions, called a hook procedure, on the back of the heel, and also assist it with this device. Typically you want to pull up to prevent equinus. In this situation, so if you had somebody who had a fracture, open fracture of the ankle, you want to pull towards the patient's nose. In this situation, it's actually the opposite. So again, it's customized to each individual. So this is a big incision along the side. I harvested the fibula bone, which is the bone on the outside of the ankle. You have no choice in these situations. You have to get bone, but furthermore, you have to expose the joint. And you can't do it on the inner aspect. There's a lot of blood vessels there and tendons, and from the anterior aspect is kind of limited and restricted. So this way you can access all the joints, as to most of the joints on the side, with a big L-shaped incision. So the fibula was removed, the tibial talar joint, which is the tibia and the talus, articular surfaces have been scraped off using multiple instrumentation and packed with bone. And his situation was phenomenal. I took a piece of the fibula and it was a perfect match, and then reinforced with the head of the fibula. I took that piece. Everything has to be cleaned up, by the way, off the soft tissue. You have to have solid bone. And what I do is kind of fenestrate the bone, have the assistants or the resident fenestrate the bone to try to kind of decortify it a little bit for incorporation. And what I did is rotated the fibular head and screwed it to the tibia and screwed it to the heel, and it worked phenomenal for him. His heel was slightly invalgus and unfortunately would not be corrected. It was acceptable otherwise, and it worked out for him very, very well. And obviously the subtalar joint was scraped and packed with bone and stabilized with hardware. But nonetheless, the frame is what I wanted to show you guys what it is. And he still requires a procedure along the inner aspect of the arch. But what's good about all of this, as we saw before, he had a rocker bottom foot. Now what we see is he has an arch. And that's very, very nice, very beautiful. Before it was a convex, and now it's a concave. So nonetheless, this is the skin graft. This is the pin. So if we look at it from top to bottom, second toe to knee, that is straight as an arrow. And that's what looks beautiful. His foot has accomplished exactly what needs to be. The weight is distributed properly, hind foot to forefoot, as well as lower leg. This little dislocation that he has will be grinded down a little bit. And fusing that last joint, which is the TNJ, the talar navicular joint, and we'll be done. And again, so this is a procedure for the Charcot, and hopefully that would be beneficial for other people out there. Thank you.